Good afternoon. I want just to thank and congratulate Professor Dr. Hisham Awad, Professor Dr. Nihal Ragel, Professor Dr. Safa, and the whole neonatal ICU team for this conference. And I would also want to thank the speakers because the session was very inspiring, but the drawback is that we have a lot of questions, okay? Yeah. Okay, we all know most of the questions are directed to Dr. Yasser. If you prefer to come to the stage. Okay, yeah, okay. So we all know that any human body will be born with a high pulmonary vascular resistance. After how many hours after birth, we will start to define the pulmonary hypertension.
Yeah. So, yeah. So there's a very important question. So, and thank you. Yeah, I'm okay. So that's fine. So the pulmonary vascular resistance is expected to drop over time, and there is two stages or two phases of pulmonary vascular resistance to drop from the fetal level to the established postnatal level. So the first drop the pulmonary vascular resistance after adequate expansion of the lung, either in preterm or term infant, and then normal oxygenation. So the infant, we assume that the infant got enough oxygenation in a good lung expansion. So this drop will happen acutely during the first 6 hours, and then plateau will continue the first 3 days. That we call it the postnatal transition after birth. And then the same pulmonary vascular resistance will continue to drop gradually during the first 4 weeks of life. During this period, during the first 3 days, the chance of development of pulmonary hypertension is high because the pulmonary vascular resistance is very still sensitive to any changes in the oxygenation. And it is during the 4 weeks still high, but not as the same as beyond the 4 weeks of age. So this is in case of normal transition. If the infant exposed to any kind of parental asphyxia, either antenatal, intrapartum, or postnatal, then the circuit of this transition will be interrupted. Then the pulmonary vascular resistance will be almost the same like the fetal circulation. That's why we call it persistent high pulmonary vascular resistance of the newborn, or PPHN, persistent pulmonary hypertension. And I need just to justify another important point about the physiology. Not all of the premature infants or term infants are the same. So in very nice description, animal studies in the Dr. Lakshini horse SEMA was published the difference between different preterm stages. So the very preterm infants between 22 to 26 weeks, they have very tough, very high pulmonary vascular resistance, and the chances for them to develop pulmonary hypertension secondary to respiratory failure is high. And typically they have high chance of develop hypoxemic respiratory failure and pulmonary hypertension secondary to that. The pulmonary vascular resistance with the gestational age will drop to the lowest value at around 30 weeks gestational age. So we have at that level the lowest pulmonary vascular resistance, and then we'll start to go up again. I'm talking about intrauterine pulmonary vascular resistance will be very high at the very premature due to pulmonary hypoplasia, 22 to 26 weeks, and then will drop at 30 weeks, and then will increase gradually until the age of term. So when you have the most high risk two groups of to develop pulmonary hypertension, the very premature infants less than 27 weeks, and late term and the late preterm infants. In between, the chances of development of pulmonary hypertension is much less, around 30 weeks. That's due to the intrauterine development of pulmonary vascular resistance.
Actually, as regards the blood pressure measurement, okay, we all know that we care about the perfusion more than the number or the figure of the blood pressure. So if we have a good perfusion, what is the lowest acceptable figure for diastolic blood pressure or pulse pressure?
Yeah, that's a very important question. We don't know the answer, simply, because we don't know what's the number to fit for every patient. Every patient is different, and every patient fit is different. So I cannot assume, I cannot give you a number that, based on that number, that number is low, you need to go for medication or you need to go in for interventions. It is based on multiple factors. So we have the table that I showed you. So there is a number is different according to gestational age and also according to the stage of postnatal transition. So the first day of life, we accept lower blood pressure compared to the beyond the first day of transition. And in very premature infants, we, for example, 23 weeks, the diastolic blood pressure can be as low as 13 or 14, as with two conditions. What are the two conditions, regardless of the number? I don't care too much about the number. I care about the trend over time of the blood pressure, because I might have a premature infant with diastolic blood pressure of 14, and the blood pressure is stable, no lactic acidosis, stable otherwise, good perfusion, and no other issues, and it's plateau. And I may have infant with the diastolic blood pressure of 19 or 20, it is higher, but it's still compromised because the trend is decreasing gradually with poor perfusion, and the heart performance is poor to cope with this resistance or this diastolic blood pressure. And then we'll get in this situation the pulse pressure narrow. So not only about diastolic, so we need to look at the three numbers altogether. The diastolic blood pressure, the pulse pressure, and the systolic. But the most two independent numbers that we need to look at is the diastolic and pulse, because the systolic typically is a sum of both diastolic and the pulse pressure. So the take-home message from that, don't look just as a number. Number does not mean anything. It is based on the trend of the number. That's why in very critical babies we are using invasive blood pressure. Because invasive, you can get the trend very easily, minute by minute, and you can detect any deviation easily. Again, if you don't have invasive blood pressure, you can use frequent measurement by invasive. Yeah, that's very good. Yeah, usually you're using an upper limb, one of our limbs. Yeah, usually you are using in one of our limbs according to the convenience of the bedside nurse, because you only have one limb with the lines or any other interventions. So it might be difficult to keep one limb fixed for the measurement. The most convenient one, and we are lying in one of the upper limbs, arms. Sure.
And the aim of my questions is to address the problems that we face every day and the points of negotiation between the cardiology side and the neonatology side. So we insist that we care about the diastolic blood pressure. I care about the diastolic blood pressure not to be below 20, because this is the coronary perfusion, this is the myocardium, and I don't care about any other number except that the pulse pressure will ensure your perfusion. This is my point. I don't know yours.
Yeah, that's very good. In very premature infants, sometimes we see the diastolic blood pressure even out. Yeah, yeah, and maybe older, maybe more than 28 weeks or so, around 20 is reasonable, but I'm just including also very premature, like 23, 24, 26 weeks. We see that the diastolic blood pressure is 15, and we don't have to do anything. Yeah, and it's plateau, good perfusion, there is no lactic acidosis, there is no increased oxygen requirement, everything is okay. So don't actually just look at the number. Number is important, but look at the trend. It could be 20 now, and in 1-2 hours, it might be 18, 19, 18, 17, so it's going down. So the trend is down means that we are going in a different direction. Very good, thank you.
Okay, Dr. Yasser, my question, Dr. Yasser, if you question tell you, Dr. Umayma. Dr. Yasser, about dysfunction of right ventricle that happen with chronic lung disease. Yes. I'm talking about short-term management when the baby is still in the unit, and full follow-up during maybe the first few months of life after discharge. So how can we do, I mean, with the reflection of pulmonary hypertension on the right ventricle?
Yeah, so you mean the pulmonary hypertension during failure of postnatal transition premature infant, because there is chronic lung disease later on associated with pulmonary hypertension.
I'm talking about the time when it persists, when the lung pathology changes and the pulmonary hypertension happen, and then baby will be discharged. So management while still in the unit.
Yeah, you mean the chronic type, the chronic lung disease.
Chronic type.
Yeah, so first we see more RV dysfunction associated with pulmonary hypertension for the acute. Acute, I mean the early hypoxemia or hypoxemic respiratory failure associated with pulmonary hypertension. We see more RV dysfunction with them. For the chronic lung disease, pulmonary hypertension, that's kind of rare. in this case. I can remember that maybe last few cases we referred the case for cardiac case because of severe pulmonary hypertension with RV dysfunction. That's not really common, and you need really severe chronic lung disease with severe high oxygen requirement with hypoxemia to get into the level of RV dysfunction. And usually we don't wait until we reach that level, because we have the nitric oxide. That's really a very effective medication for pulmonary hypertension. And we can use a second line, like sildenafil. We use it in infusion, not intermittent, in acute cases. That's also more powerful and more steady level for the serum level of as a pulmonary vasodilator compared to intermittent doses in more stable cases. So we have multiple level of interventions before we reach that level. Second, we are screening infants with chronic lung disease, so we don't wait until we see them in failure. So once we have the pulmonary artery pressures almost 2/3 systemic or close to systemic, we intervene immediately with the pulmonary vasodilators and close follow-up. Like that's why very rare to see the infant reach that stage, late stage of RV dysfunction in chronic cases. I'm not sure if the experience here is different with your.
Please.
الدكتورة أميمة بس سؤال الحقيقة how can lung ultrasound help in post-operative patient في neonatal unit, especially those have been subjected to intervention for diaphragmatic hernia or for congenital heart disease, where there's a multiple adhesion and pockets and all of this. Can it help, or just you need to be radiologist?
Yeah, I think it definitely helps. Even if something not related to the chest at all, let's think of anyone with intestinal obstruction, NEC, for example, and then those babies like passing through a stage when we have to, you might have like pulmonary, excessive fluid intake, you know, the baby's not passing urine still, maybe paralyzed with a lot of painkillers at the beginning. And you will see like, and maybe also on top of that in shocked cases with NEC, you might have also like fluid leak. So with all that, you will have edematous lungs, we have pulmonary edema, and you will have decreased compliance, and this will affect your management. Are you able to extubate the baby, wean the painkillers and extubate, or you need really to do fluid management and increase or improve the lung compliance and optimize your ventilation. So looking with the lung ultrasound straight away, and you can start to see like the B lines filling the lungs all over, you know what stage are you. Just a quick example, like I had a baby recently with NEC, came to us shocked, and just the surgeon said, I'm going to do the surgery inside the neonatal unit. Baby is too sick to be transferred. And straight away, just before, and the baby was on high pressure support, 28/7, oxygen was initial like 50-60%, and suddenly desaturated just before we start the surgery. Baby was intubated, got lung line straight away. This is what we've done in the neonatal unit, an arterial line. Then the anesthetist was managing the hemodynamic part, and I was managing the pulmonary part, and the surgeon is doing his surgery, of course. Okay, so straight away the baby, before we start the surgery, just sudden collapse, sudden requiring oxygen up to 100%, and the baby was not saturating great. So I used the ultrasound, and I said, oh, possibly because of the high pressure developed pneumothorax. Wasn't pneumothorax. And the lungs was really, you can still some air lines there. The baby was already dry before the surgery. And you can see some areas of collapse because of the, the over distension of the abdomen. So I concluded that this baby is just having severe pain, and I asked the anesthesia doctor just to start with the fentanyl. And as soon as we've done that, we already had better oxygenation, and we didn't require anything else. Just imagine, to rule out pneumothorax, how much time we could have lost or wasted until we get the diagnosis. For the patients with diaphragmatic hernia, of course, we know, again, post-operative, you can diagnose air leaks very easily, you can diagnose collapse. You can, again, you have the problem with fluid overload and pulmonary edema. So all this, and it's simply like few artifacts, A, B, and C. Okay, thank you very much.
No, at all. There are just 2 points I want just to confirm. They were, Dr. Yasser told about that In type 2 and 3 morphological pulmonary hypertension, I think exclusion of coarctation is warranted before going to the vasodilators, because this is very important. Another thing is pulmonary venous hypertension. We can diagnose it very easily because we can measure the pressure gradient across the PFO. If it is more than 5 millimeter mercury, we have a high left atrial pressure, and this will diagnose the presence of the pulmonary venous hypertension in order not to use the vasodilators. And this is very important. Whenever we have this jet across the PFO, it's contraindicated to give any vasodilators. I'll go with the questions. Okay, yeah, at what threshold you will, of metabolic acidosis, you will correct the metabolic acidosis prior to starting vasopressor?
Yeah, at what threshold?
Yeah, that's another important question. So sometimes we may consider both at the same time, because if the infant is really critical, we may use the medication, and we are not expecting that medication will be effective unless the pH is more than 7.2. Usually, if the pH less than 7.2, there is impact of the acidosis on the pulmonary vascular resistance. And this acidosis might be metabolic or respiratory, whatever. And we have seen a lot of cases on the respiratory support, and CO2 was 90, 100 or so, and the infant would develop hypotension. The only thing that you need to do in this case is just to correct the ventilation without start of any vasopressors. So if the condition is really respiratory related, you need just to correct the CO2. If the condition is metabolic, it could be metabolic secondary to the initial issue is, or the initial problem is the low blood flow. And this low blood flow can be vasodilator physiology or whatever reason of hemodynamic instability. Then you may consider both at the same time. So based on the type of acidosis, again, we are trying to target more than 7.25, but typically less than 7.2, you may get loss of vascular tone. In this situation, usually vasopressor, not the inotropes. Vasopressor is the medication that might be effective. And vasopressors, I mean in our unit, we are using either vasopressin, I'm not sure if you have here telepressin or vasopressin infusion, and or norepinephrine. Yeah.
Yes. What's your opinion, Dr. Yasser, about using the magnesium sulfate in cases of pulmonary hypertension?
We are not using magnesium sulfate. That's
okay.
Probably
so
20 years ago.
In situations,
when last time you used the magnesium sulfate, Ruben?
Yeah, okay, but in our situations, we are lacking the nitric oxide, so we have to play with another thing.
Yes,
so
your situation
what do you
is different.
prefer?
Yeah. So you have sildenafil, and sildenafil is stronger by evidence to be used. So I assume you have, right? So you don't have infusion.
No, no.
Yeah, that's even more difficult. So if there's contraindication to give oral, then you're stuck. Yeah. So
So yeah. What about the
other options?
Merinone. What about the Merinone?
Yeah, Merinone, we are using Merinone in one very common indication, pulmonary hypertension is RV dysfunction, because it is not basically a vasodilator medication. It is typically a medication that improves the diastolic compliance of the heart, lysotropic, and there's a side effect that might lower the blood pressure because it's also systemic vasodilator. One of the issues of Merinone that you have to be cautious. Merinone is a medication that recommended in our unit either from the cardiologist or from the neonatologist trained in hemodynamics. So not everyone can use Merinone. So Merinone is a medication with long half-life. It's about 4 to 6 hours. It's not the same like dobutamine. Dobutamine is few minutes. If you stop it now, like if you use it like as wrong medication, not really indicated, you can stop it and you can reverse the effect. But Merinone, you have it in the circulation for 4 to 6 hours. Then you need to use another medication to overcome the side effects, which is norepinephrine or whatever. So that's why it's better to be used in the right indication. It is an indication in our unit, pulmonary hypertension with RV dysfunction or LV dysfunction. Pulmonary hypertension with normal performance heart, that's not in our recommendation at least, or not at the Canadian Pediatric Society statement that we published recommended.
stop. So
Yeah,
in
if you
our
use it as a
corner
pulmonary
situation,
vasodilator,
what to do?
so
In our corner
I'll give you
situation-
some options. I'm not sure if that will be applicable or not. So if they have severe pulmonary hypertension and there is a RV strain, you use a prostaglandin. Prostaglandin is a medication that can open the ducts to relieve. We should be happy when you see right to left shunt. Don't work to increase the systemic resistance and reverse the shunt. When you see right to left shunt in pulmonary hypertension and the oxygenation getting improved, and blood pressure is stable, you are good. So prostaglandin also is a medication that might lower. We have seen the pulmonary artery resistance might be lowered by prostaglandins. Another medication which I'm not sure is available here or not, which is prostacyclin. You don't have prostacyclin. So prostacyclin is one of the lines, but not the priority. We can use it sometimes. It's effective as well. But I think you need to work in to get the infusion sildenafil. Something not available, just ask for it. Simply. It's not very expensive.
You're standing there on a micro-controlled trial, and unethically you cannot use magnesium sulfate, so you use nitric oxide and use an hour length
Yeah.
magnesium sulfate. You can cook with
Yeah, just I don't have experience with that, so I can't advocate for something I'm not really familiar with it.
Okay.
Yeah, but anyway, I'll tell you one more thing, which I feel bad about it. Nitric oxide is not expensive medication or gas. It is expensive in Canada because there is few companies like control the use of it by a meter or whatever, and it's $200 per hour. It is crazy expensive. But I found in Saudi Arabia some hospitals, they are using tank from the industrial, and it is available and used successfully without
it's
any
a
issue.
security issue.
Sorry? Yeah, but you can modify it in a very cheap way to get medical. Yeah.
Security.
Yeah, but you need to solve it
Yeah.
because it is a critical medication that
Okay.
should be available.
Okay.
Yeah, I'm not sure. We never used it. Yeah, maybe like the oral dissolved medication is more like the compliance for the nurse will be easier for the oral and can control the dose easier compared to the lingual. And the absorption is very good. But the idea, if you have someone with MPO for any reason, then you need to give everything IV.
I know this has been mentioned before, but they are asking again about the difference in treatment between pulmonary hypertension of left to right shunt and the pulmonary hypertension in right to left shunt.
Yeah, that's a very good physiology question. And I will actually clarify from the physiology that pulmonary hypertension is two types, like based on the resistance or flow. So when you have high resistance, and the resistance is high enough to get the RV pressure higher than the LV, you will get the shunt right to left. So it is suprasystemic pulmonary artery pressure. But when you have subsystemic pulmonary artery pressure, like 2/3 systemic or less or whatever less than systemic, you will get the shunt either bidirectional or left to right. In this situation, it's mild. In a lot of situations, you don't have to even treat it. We usually consider significant pulmonary hypertension when you have the pulmonary artery pressure equal to systemic or exceeding systemic, or with RV dysfunction. These are the bad types of pulmonary hypertension. One more thing I would like to clarify. Based on the physiology that we described, pulmonary hypertension also might happen with the lung flood. It means that when you have left to right shunt, secondary to AV malformation, or in preterm infant left to right PDA. It is another type of pulmonary hypertension, but with high flow, because the pressure is directly proportional from the physiology, resistance multiplied by flow. So if you have flow, it is also pulmonary hypertension, but not the pulmonary hypertension that you need to treat with lowering the resistance. You need actually to increase the resistance. That's why one of the non-medical treatment of the PDA, as I mentioned, we allow lower target saturation to increase the resistance. And if you are using medication, like ibuprofen or whatever medication to treat the PDA, at the same time accept lower target saturation, that's still physiologic, and keep the lung inflated. So if the infant on CPAP, don't wean CPAP while treating the PDA. So you need to increase the stenting pressure that will limit the left-right shunt. This is a type of pulmonary hypertension, but with high flow. In one of I was in Turkey, and one of the questions that it came, one of the colleagues in Turkey, in the pediatric cardiologist, they are writing in any left-right shunt, significant left-right shunt in PDA, there is pulmonary hypertension. So some of them, after my presentation, they got confused, and they are asking, our cardiologists, they are confusing us. They are writing preterm infant with left-right shunt through the PDA with pulmonary hypertension. I told him that he is correct physiologically, because it means that the left-right shunt is high enough and the flow in the lungs is very high to increase the pressure. But it is not the high resistance pressure, it is the high flow pressure. I hope that I answered the question.
Yes, in continuity with the same question. If you have a BDA with a bidirectional shunt, whether to close or to give vasodilators?
Yeah, that's very good question. Thank you very much. That's very common questions from when we do by echo. So bidirectional is not just one bidirectional. So there is definition of bidirectional with significant right to left diffraction. So usually when you have bidirectional shunt, we have the right to left part during systole and left to right during diastole, usually. So if it is the duration, if they have the duration, and that's actually a very good definition by Dr. Evan Snake from Australia, if it is more than 30% of the cardiac cycle, that's significant. If it is less than 30%, we consider that left to right. So that's negligible right to left diffraction. So if it's bidirectional, you need to ask the cardiologist. You are telling me there's a bidirectional PDA. So the right to left shunt, is it significant and more than 1/3 of the cardiac cycle? Then you should not treat and you should wait, because it could be just postnatal transition, and it might, in 1 or 2 days, might be left to right. It might in just no time, even in hours. But if the right to left shunt is less than 30%, I don't even write it in the report. I just write left to right shunt. It is negligible fraction. Make sense?
Can I add something?
Yeah, sure. Yeah.
Okay. If we have a left to right across the BFO, even if the BTA is bidirectional, we will close. If we have a dilated pulmonary veins, even if the BDA is bidirectional, I'll close.
Yeah. So even if the bidirectional is like even more than.
It's not actually a bidirectional, because if we have a dilated pulmonary veins, meaning there is a lot of blood going to the lung and there is a lot of blood coming to the heart, meaning there is no pulmonary hypertension.
That's very good. May I add one more thing?
Yeah.
So it is not only based on the direction. So in the PDA assessment, when we write the hemodynamics report, we have too many things to add, which some of these parameters not really common to be reported by the pediatric cardiologist. Some of them are related to peripheral circulation. So if you see a PDA, there's two parts of the PDA physiology. There is a high pulmonary blood flow part and the low systemic blood flow. And the high pulmonary blood flow, we see many things. One of them, when you have the left atrium aortic ratio is higher than 1.5. So you have dilated left atrium. Then I don't care, as you said, about the direction. It might not be really accurate. When we have the ratio between E and A phases in the mitral inflow, if you are familiar with echo, so usually in preterm infant is E less than A. When it is reversed and E more than A, it is a sign of diastolic dysfunction that might be associated with PDA. So we can consider also one of the signs of high pulmonary blood flow. It is also the PDA size and ratio between the PDA size to the left pulmonary artery. We are not using a cut limit for a PDA size. We are using the left pulmonary artery diameter as a reference, because 1.5 PDA might be large for 23 weeker and might be small for 30 weeker. So we are using the left pulmonary artery as a reference to refer to the size. If it is more than 1, it means significant. 0.5 to 1, moderate less than 0.5, it is small. So the ratio between left pulmonary artery, PDA ratio. And there is a systemic part, which you usually are not doing that as a routine. We assess the celiac artery Doppler. You are usually relying on the descending aorta or arch, descending aorta or arch aorta, the reverse diastolic flow. We assess also the renal artery, celiac artery, diastolic flow. It is absent or reversed. And also middle cerebral artery or anterior cerebral artery. Any one of them reversed or absent, it is a sign of significant stealing of blood. So it is not only based on the direction. It is a lot of factors, and we have created a score And this score is available as electronic score in our like a website, newbeats.academy. And you can use the score to the software, this artificial intelligence will give you the feedback if this PDA should be treated or PDA you can just watch, based on all of these parameters, and should be integrated to the clinical. So our colleagues from pediatric cardiology, they do the echo and interpret the echo as images. We should integrate that with a clinical assessment. For example, if you have a PDA, which might be moderate or large, by your assessment, and the infant on CPAP in room air, I don't care. Like the PDA significance should be clinically significant, so the PDA cannot be weaned, requiring more oxygen, and so on. And we had before a lot of cases, maybe more than 10 years ago, Ruben, when we consider ligation, even the infant on CPAP because of large PDA, failed medical treatment. We are not doing that anymore. So that's like ancient in our unit. We are not considering ligation for any infant, just multiple doses and the PDA might close by itself. Even if you leave it, it will close. So don't consider it as really big issue in your unit. And sometimes non-medical treatment might also help to limit the shunt.
So I want to thank Dr. Yasser, and I want just to convey a small message that thoroughly every day I got 10 rappers, 20 rappers saying that the pulmonary artery pressure at 35, pulmonary artery pressure at 40, 45. This is not a pulmonary hypertension. Accept those levels early in life. If the pulmonary artery pressure even is 60 in the first day, nothing. Do not give vasodilators if you please, because the patient is taken as a whole with other markers to address other than just a number of the pulmonary artery pressure. Thanks, Dr. Yasser. I hope I
دكتورة نيفين بتقول الرسالة اللي احنا بنقولها frankly no sildenafil اللي بيتاخد عمال على بطال على pulmonary pressure in the first few hours of life of 35 and 40 or maybe even more. ما فيش أي clinical significance. Don't give sildenafil, please. Yes, and PDA don't close it early. In 24 hours, it doesn't need, it will close on its own. يعني.
دكتور ياسر معلش سؤال. بيجي لنا reports from time to time from our colleagues of obstetrician telling us that this fetus is having pulmonary hypertension. Is this rational? And is this, because pulmonary hypertension in the fetus is a physiological process, and are you going with recommendation to give sildenafil to the mother? Is there any rationale for this practice?
Actually, I'm not sure how what parameters they relied on. Probably when the right ventricle is too much dilated, I'm not sure how they can comment on the vascular resistance antenatally. So but you remember that we get any report from? Yeah, sure, yes, yeah, go ahead.
Yeah, because actually I have some work in perinatal medicine. So actually, can I answer, Professor Hisham, if you permit me? Okay, to rely upon the TR to diagnose pulmonary hypertension in a fetus is completely nonsense. Okay, because this is not the RV of the systemic ventricle during the intrauterine life. There are some studies which is still experimental on the flow across the ductal arch, and some studies telling that we can expect if the pulmonary vascular resistance will drop rapidly in this fetus or not, especially in the infants of diabetic mothers or the fetuses of the diabetic mothers, and still experimental, and the sildenafil during pregnancy is useless, is totally useless.
Yeah, I just a comment on one more thing. Yes, I agree 100% with you, doctor, about that. So we never came across such report from the antenatal. We have very highly dedicated antenatal screening program with the fetal echocardiography like team, and I can't remember that we got such report. The only thing that might be contributing early closure or intrauterine closure of the PDA, you may like see some effect with the RV or heart like dysfunction, and that can be detected by antenatal ultrasound or fetal echo easily. Only in that situation I may consider this really critical sign. When you see the PD is closing, that can be used by use of some antenatal, use of some maternal medications like non-steroidal anti-inflammatory drugs, or some of the antidepressant might induce premature PDA closure. In this situation, that's emergency. Then we have to intervene. That's the only thing in my knowledge that needs urgent intervention. When I see the PDA is closing or closed already, and the RV is straining or very dilated or dysfunctional. But comment on just pulmonary hypertension, and that's not.
In such situation, you are going to give the mother sildenafil?
No. Yeah. No. You get exactly. Yes, because the infant, typically the fetus will die if the PDA closed and not. Yeah.
And that's why they have stopped using indomethacin as tocolytic.
Yeah.
It was used previously.
Exactly,
As
yeah.
tocolytic. And for this reason, because from time to time we face these babies are delivered with a mother who received indomethacin and tocolytic, and they collapse in no time and they die with severe intractable pulmonary.
Even, like I know that some mothers are also using paracetamol and prescribed by physicians. Even as reported cases of paracetamol can induce fetal ductal closure. So don't assume that any medication can be used during intrauterine life is 100% safe. There is a significant range of danger. So don't use any medication. Yeah. Without any clinical indication.
ربع ساعة فقط. ربع ساعة علشان احنا متأخرين وفي فرح بعدين في القاعة. ممكن